give the introduction to a phenomenal guest that we have here today for the DeBakey Heart and Vascular Center Grand Rounds. I'm going to start by saying Dr. Kirkwood is the chief of the Division of Vascular Surgery and medical director of the Clinical Heart and Vascular Center and medical director of the Vascular Lab at UT Southwestern Medical Center. She also holds the Patrick Clagett, MD, Professorship in Vascular Surgery. Dr. Kirkwood with us today, graduated from Yale University School of Medicine and completed her Gen Surg training at the University of Chicago Medical Center, and then went on to do a vascular surgery fellowship at the Hospital of the University of Pennsylvania. She also recently completed an advanced leadership development program for physicians in academic medicine at the Harvard T.H. Chan School of Public Health. She specializes in overall procedures of vascular surgery, but her research specifically centers on patient and operation radiation exposure during complex endovascular procedures. And she has published extensively on this topic and is obviously an international speaker at this level. She serves as chair of the leadership committee for the Society of Vascular Surgery. And obviously, she's a reviewer of her own journal, as well as the Journal of Annals of Vascular Surgery. So with further ado, Dr. Kirkwood, it's an honor to have you here. Thank you for sharing with us this morning, and we're incredibly excited to hear your presentation.
Thank you. Thank you, Dr. Baker. I am just so excited to be here as well. So I'm going to share my screen now. All right. Are you able to see that?
We are.
Wonderful. Well, again, thank you so much for this opportunity to you, Dr. Baker and Dr. Lumsden. What a pleasure it is to be here today. So today we're going to talk about radiation safety for the cardiovascular interventionalist. These are my disclosures. So to begin with some objectives, we're going to define some commonly used dose metrics, discuss different forms of radiation injury, describe what types of radiation we're exposed to as providers, how we can limit that dose. So as we all know, procedures are becoming more and more complex. And with that, the dose associated with those procedures is increasing. So two numbers to keep in mind is 5 and 15. So the National Council on Radiation Protection has set a threshold for a substantial radiation dose to be anything greater than 5 gray. Now that's a reference air kerma dose, not a skin dose. And we'll talk a little bit about that later. And then up until this year, the Joint Commission defined a Sentinel event to be any endovascular procedure that reached 15 gray. So recently, there's been some changes to the Sentinel event policy. They got rid of the 15 gray, and now a Sentinel event is if a patient has permanent cutaneous injury and the proper dose-saving techniques were not used by the interventionalist. So that could include anything as low as 5 to 7 gray, potentially to have some skin injury, which could be as minimal as just permanent hair loss, could be investigated. So your documentation in high dose cases should include that you followed best practices during the procedure, and that patient should have follow-up with dermatology. So some dose metrics. In the literature, fluoroscopy time is often quoted. However, overall, fluoroscopy time is a poor indicator of dose because it omits all of the dose from digital acquisitions. And as we'll see, the digital acquisitions are much higher dose than just fluoro. The dose area product is the total radiation output from the X-ray tube, and that's the dose times the cross-sectional area of the beam. That's a better indicator of your cancer risk or perhaps your operator exposure. Whereas the reference air kerma is the best approximation of patient skin dose. The reference air kerma is just the dose at a reference point. So the interventional reference point is 15 centimeters along the beam axis towards the focal spot from isocenter. So it sits appropriately where the patient's skin should be for an average size 70 kilogram patient. So obviously, if the patient is larger, the skin dose doesn't exactly mirror the rack. So where is rack displayed? So rack is displayed as a rate when you're on the pedal and as a total dose when you're off the pedal. So it's important to keep track of kind of both those numbers throughout your procedure. So overall, there's two major forms of radiation injury, deterministic and stochastic. So deterministic effect, this is a patient with a deterministic skin injury effect. That could be, as we discussed, skin injury, but also cataracts in the operator. It's thought to be a dose-related response with a threshold level that must be achieved prior to any injury. Whereas your stochastic injury, which is your cancer risk, is not dose dependent, but the risk of it increases with your overall increase in exposure. So this is, a very common dose chart where where the literature kind of points out at what level and what grade injury you can see. So you can see at skin doses as low as 2 and 5 gray, you can start seeing some early epilation, some redness. Whereas 5 to 10 gray, you can get some dermal atrophy or induration. And at greater than 10 gray, you can have some really serious injuries. So we looked into this in both a retrospective study, looking at all of our skin doses retrospectively, and then followed that up with a prospective study following the patients that had significant high dose. And what we found was we do actually have, at least, prior to some of our education, we did have some significant high dose cases. And again, these are skin dose cases, not even rack cases. So some high skin dose cases. But what we found in all of these procedures combined is there were no skin injuries detected, even when we were specifically following skin exams in the outpatient setting. So what that tells us is that, skin injury is probably multifactorial. It probably also has some patient factors that have yet to be completely uncovered. And it is a rare occurrence, but definitely something you need to keep an eye on. So what about as an operator? What are we exposed to? So when you put your hand in the beam, you're exposed to the primary beam, which is very high dose, and we should always avoid that. The leakage radiation is what comes out of the X-ray tube, and that's pretty low. That's regulated by the FDA and checked, routinely by your medical physicist. So our major dose of radiation is actually scatter radiation, which is coming from the X-ray tube after hitting the table to our lower legs and attenuated through the patient to our upper body. So we looked a little bit deeper into what surgeons or interventionalists in general are exposed to during these complex endovascular procedures, and what are some of the factors involved. And so it does make sense that your position around the table is directly related to your radiation dose. So what we found is that person A has twice the dose pretty much as position B. The good news for all the medical students listening is that C position uniformly, even for very high dose fevers, had almost 0 dose. So the further you get away, obviously your dose is significantly less. What is very interesting to us and changed our practice is that the left brachial position, the D position, was even higher than the A position. And that's why we now use right brachial access for all of our fevers instead of left brachial access. We also found that obviously it depended on the case you were doing. It's a marker of complexity. So for our fevers were our highest dose procedure, followed by embolization procedures. And then you can see how the other ones fall out. Some adjuncts to lower your radiation. So we noted that the table-mounted lead skirt was extremely effective in lowering your lower body dose. It makes sense that it had no change in your upper body dose because your upper body dose is coming to your chest through x-rays already attenuated through the patient. But your lower body dose was very much decreased by that table-mounted skirt. So always important to remember to add that on. This year at the SAVs, we presented a bit on the lower leg wraps and found that even with all cases using the table-mounted lead skirt, that adding the lower leg wraps during complex procedures dropped the radiation dose by 95% to the lower legs. So if you can tolerate these, they can be a little heavy, but if you're doing a high dose case, I think it's important to shield this area of your body that is often unexposed. So knowing that fevers, at least for our division, were the highest dose cases, we took a deeper dive into the fevers to find out what are the factors and which ones are higher dose and lower dose. And what we found is that, again, most likely a marker of complexity. So 4-vessel fevers were a higher dose than 3-vessel fevers were a higher dose than 2-vessel fevers. And when broken down by device, custom-made devices were higher than off the shelf, and both were higher than a routine ZFIN device. We also wanted to break it up by gender. There were some concerns by our group that perhaps women would have a higher radiation dose because they have maybe more tortuous iliacs, shorter angulated necks, things that might make the anatomy more challenging and the procedure more difficult. But we found here that actually females were significantly lower when looked at than males. So at least this not completely explains why females were lower, but that females can have FEVAR safely without undue risk for skin injury. So what can we do? We know that radiation is high. We know we have to take care of these patients. So what can we do to protect ourselves? So this was one of our first papers. So many years ago, we had a very high dose case and we had a talking to by the medical physicist. And so, we decided to do some research together. And what we did was we looked at all of our procedures before and after that 1 hour talk by our medical physicist to see, just simple techniques. Can we decrease dose? And we found a significant dose reduction with just this 1 hour teaching session. And so applying basic techniques really does work. And so we're going to go through a few of those right now. So it sounds obvious, right? Be aware when you're on the fluoro pedal. But when your new fellows start, when your new residents start, they often stand on the pedal a lot longer than they need to. And especially if something's going wrong on the case, you can find yourself on the pedal. So it's important to remember to take your foot off the pedal. Each different operating system has different flavors of fluoro. We tend to use Philips, and so they have fluoro flavor 1, 2, and 3. And so as you go up in fluoro flavor, you're going up in dose. Now, sometimes it's necessary in a very large patient because increasing the fluoro flavor increases your spatial resolution and helps you see better. It degranulates the image. However, you can see that not only are the frame rates increasing, but the aluminum and copper alloy filters are being pulled, which gives you a stronger beam. So if you have to go up, make sure you go down. Just the other day, I had to go up on an obese patient, and thank goodness my tech came in and said, Dr. Kirkwood, you forgot to go back to fluoro flavor 1. And I had been proceeding with the case in fluoro flavor 3. So it's important to be mindful of that. As I mentioned earlier, digital subtraction has exponentially higher dose than fluoroscopy. So what that means is if you don't have to do a DSA to see what you need to see, you could try using fluoro looping. So if you just need to make sure that you actually cannulated the renal, and you're not in a lumbar or something, you could just stand on the fluoro platter, shoot a little dye, and then tell your tech to loop it. And it'll keep playing if you need to see it again. But that over time does limit the dose if you don't do a DSA every single time. Most systems are set to automatically use angio multiphase. That means that the frame rate is reduced in later stages of the angiographic run. If your system isn't set this way, obviously talk to your X-ray techs because it is important to be able to do that to just overall lower the dose of your DSA runs. So we talk a lot about limiting magnification. Well, that's because magnification substantially increases the rack. So on flat panel systems, your rack increases inverse proportion to the field size. So halving the field of view by pushing the mag button once doubles your rack rate. So it's a very significant increase. And if you do have to mag up to be able to see better, make sure you collimate. So collimating, decreases the overall field of view. So your scatter radiation dose is less. So we were having to use magnification a lot to do some of these complex fevers, and we were wondering if there was a better way. So we looked into this new technique, which is dual fluoroscopy with live image digital zoom. And we wanted to see whether we could decrease the overall dose with this technique as opposed to your magnification. So what I mean by, so on a Philips system, when you look at the regular magnification buttons, so that's image zooming using standard electronic mag is achieved by changing the detector field size, which results in increased radiation dose. But if you go to the zoom control panel, you can adjust the processed image and make it much bigger on a scale of 1 to 5. And that doesn't change the dose at all. Now, it doesn't increase the spatial resolution. So the image is still a bit grainy, but it's larger. So if it's just that for us, sometimes our screen is kind of far from our eyes, if you just want the image bigger, the digital zoom is definitely the way to go. And when we looked at this, we saw that using just changing digital zoom compared to electronic mag definitely decreased the patient dose and the operator dose. So some important principles to remember. Dose rate at the image receptor is maintained at a constant level to preserve image quality. So that compensates for variations in patient size or attenuation. So if you have a very large patient, your table is going to be lower. Your image receptor is going to be further from your X-ray tube. So it's going to have a feedback loop that tells your X-ray tube to increase the radiation dose. And the other important principle to remember is that radiation dose decreases as 1 over r squared from the source. So doubling the distance from the source decreases your radiation by a factor of 4. So that's why we always say keep the table high, because you're moving the patient away from the source. You're decreasing that patient's skin dose. And then keep the image receptor close to the patient so that the feedback loop is minimized. It's important also to avoid steep angulation if you can, and to keep the extremities out of the beam for the mere reason that in a oblique angle, the patient is thicker and therefore the feedback loop will be higher, driving up the radiation dose in those steep angulations. If you do have to use a steep angulation for your FEVARs or complex embolization cases, it's really important to collimate out the other area. So you can just focus on one area. And then if you ever were investigated for a high dose case and they were looking at your patient's skin dose maps, you could show that you spread out the dose by collimating and minimizing the high dose maps on the patient's skin. So this is an inside joke here. This is basically a picture of Jeff, one of our medical physicists. So it's kind of a quirky picture, but in any event, the position, the bottom line of this slide is that you always want to stand on the opposite side of the X-ray tube if you can, because when you're right next to that X-ray tube, if you don't have the lead skirt on, or even if you do, you're still getting significantly more dose than if you were able to move to the other side. Or just step back, obviously, from the table during these runs, or perhaps even leave the room. So when we're thinking about minimizing dose, it's important to stay aware of new software developments. So a few years ago, we looked at the Allura Clarity platform, which is a Philips healthcare platform, a new imaging technology that claimed to reduce radiation through various motion compensation and spatial noise filtering principles. And what we found is that it actually significantly did decrease dose. So we looked at all procedures, a few months before and a few months after the institution of Clarity on the same exact system. And we found over a 60% patient and operator dose for all procedures with just the implementation of this software. And then this year, at the Southern, we presented a similar platform on the Siemens system. And we also showed with this new platform, Clear Imaging VDL Pure Platform Technology System, it's a mouthful, you can decrease all your radiation dose for all coming cases before and after by about 50%. So just talk to your reps, make sure you have the appropriate dose lowering software on the machine, and keep them updated is an important aspect of lowering dose. So some other little life hacks for these complex procedures that we've looked at to decrease overall radiation dose is we used to always do a 3D on-table CTA to line up our roadmap image for these complex cases. And we then jumped to a 2D image. So just two plain films done in different lateral positions and use that for our roadmap. And what we found that just doing that alone was able to preserve image quality enough for us to do the procedure in the same amount of time. So it didn't change the success of the operation, but it reduced the patient radiation dose by 20% by eliminating that on-table CTA. So that's another little trick you can do. And you can ask your radiation techs to show you how to do that overlay with 2D if you're not aware of how to do that. So I always like to talk for a few minutes about what doesn't work for radiation, because there's a lot of things out there that are not really protective that we all most likely have purchased in the past. So we took a look at leaded surgical caps and the no-brainer caps, so lead equivalent surgical caps as well as leaded caps. And, the hypothesis was that they probably wouldn't protect against brain dose, since the majority of radiation to our head is coming up and not directly attenuated at our head. So we took a look at this and we studied this in an anthropomorphic head phantom. We irradiated the phantom here with a no-brainer hat with dose nanodots inside and outside the hat. And what we found and presented at the Western a few years ago is that the hat does significantly attenuate dose at your left temporal position outside of your skull. But it actually does nothing to the eye, middle brain, skull, or upper brain inside the bones. So there was zero attenuation of any brain dose from these hats. So then, because the bottom line is the temporal dose outside your skull is not at all your brain dose. And so there was no significant brain dose reduction from any of these leaded or lead attenuated hats. So then we thought, well, what about these leaded eyewears that we wear? If we're following the same principle, then leaded eyewear that just has a frame that's leaded would only attenuate direct x-rays at the level of the eye when we spend most of our time looking at the monitor. Whereas our hypothesis would be that the majority of x-rays to our eye are from scatter radiation already attenuated through the patient hitting your facial bones and your neck. And we were able to prove that leaded glasses are completely ineffective at reducing ocular radiation exposure. So we thought, well, what if we modified leaded glasses to have some leaded shielding to close the skin gap, the air gap between our eye and our face, and really protect from inferior and lateral radiation, x-rays. So we studied again just to prove that they had no effect, regular leaded glasses, then regular leaded glasses with side shields. And then as you see on the picture at the bottom, modified eyewear that literally just had, bootleg lead taped to the inferior and lateral aspect of the glasses. And what we found with that was, again, standard eyewear. So both the regular leaded eyewear and the leaded eyewear with side shields, which I know I have purchased in the past as well, had zero reduction in dose. So no relative dose reduction compared to wearing no eyewear alone in the Phantom. Okay. And then we looked at our modified eyewear in the Phantom, and it significantly decreased radiation dose by 62% to your left ocular position when you're standing at the right femoral axis of your patient. And this is just more data here on that Phantom experiment. So you can see that green is standard eyewear, so leaded eyewear. The red is leaded eyewear with the commercially available side shields. And then the blue is our modified eyewear. And there's only a significant dose reduction with the modified eyewear, and it reduced it in your cornea, your lens, and in your temporal brain. And in the Phantom experiment, it actually dropped your dose by 86%. In the clinical experiment, it was only about 62%, I think, because, in a clinical environment, your head is moving, you're not static, right? You're walking up, you're walking back, you're turning and things. But even in a clinical setting, it dropped it by 60%. So then we went a step further and thought, well, how do we make this, something more comfortable and more available to everyone? So we designed this disposable lightweight shield that can attach to both leaded and non-leaded eyewear. So we've tested it in, people just wearing plastic safety glasses, people wearing their own prescription glasses. And it only needs to be on the ipsilateral side of your face that's closest to the X-ray tube. So on the left eye, if you're standing at the right femoral axis position, it is reversible. So if you were standing at the left brachial artery position, you could put it on your right eye. And basically it has a conformable nasal bridge. So it conforms over your face. It slides onto the sleeve of your glasses. And then there's an adhesive band that sticks to your surgical mask. And what we found with this device is that ocular lens, temporal lobe, and midbrain radiation dose were all significantly increased. So if you can't see this slide completely, the blue is no protection alone, again, so no glasses at all. The green is leaded glasses in their usual commercially available form. So you see no difference there, again, compared to no protection. And then yellow is the lead glasses with the shield. But you can see what's most interesting to me about this project is that orange is just routine safety glasses or people's prescription glasses with the shield. That had just as much radiation dose reduction with our face shield than if you had worn leaded glasses. So the bottom line is, with this device, you don't even need leaded glasses. So leaded eyewear and shield decreased eye and brain dose by 83%, and the non-leaded eyewear and shield decreased brain dose by 85%. So significant dose reductions there. In the clinical experiment, you can see here we did about 15 angiograms with this face shield on. And although it varied, because again, not a static situation, but the overall dose reduction was anywhere from 79 to 99% for the clinical experiment. So in summary, basic tips to limit radiation dose that are often on the V site and show up on some CME work would be to obviously be aware when you're on the fluoro pedal, minimize your frame rates as much as possible, use low dose fluoro modes when possible, and try to use that fluoro looping. Try to not do as many digital subtractions. Keep the table high and the image receptor close to the patient. Keep the patient's extremities out of the beam as best you can. Minimize the electronic magnification. Maybe try and use that digital magnification. Step back from the table. If you do have to use intense angulations, make sure you collimate to limit the field, and stand on the opposite side of the X-ray tube or leave the room if you can during digital subtraction. So from my family to your family over there, thank you so much for this opportunity. I really enjoyed this, and I'd be happy to take any questions or answer anything that people might want to discuss. Thank you again.
Well, wow, that was amazing. Thank you. We're all here about to go into a case, and we're like, now should we go in? Like, but no, really, we appreciate what it's been very, very eye-opening in many ways. Let me ask you something that's been an issue many times. We're all here about to go into a case, and we're like, now should we go in? Like, so anyway, one of the things that we had the question was, it's been very, very work around with anesthesia. A lot of times when we have a C-arm and we want to put it on the right because we want to work on the left side to avoid exposure, it's a lot of pushback because they feel like you always have to have the C-arm on a specific side of the patient. And you know, I'll be honest, it obligates the surgeon to work on top of the patient and have their hands literally under the tube half of the case, if not all of the case. How have you been able to navigate that situation when you have somebody that has just done the same thing for many years and there's a lot of pushback from a group of other physicians?
I think that's a great question. I mean, I think that, as, surgeons, we're all on a team together, but we're captain of the ship, and we have to keep our patient and our team safe. And you can pull some of our earlier papers and I can email them to you earlier. We did look at anesthesia dose, and it's not too bad because they're often not in the room. I mean, they alternate so frequently between, at least at our team, between CRNAs and anesthesia. And even when the same person was in the room, their dose was quite low because they can do other adjuncts, right? So they have the opportunity to put that lead shield. We have a very tall lead shield. So our team often puts that lead shield just between the patient and anesthesia. And so they don't mind as much which side of the bed it's on. But you could just, I think education is important. Let them know that, trust me, we're all going to have lower radiation dose if I move the C-arm to the contralateral body. But their dose is pretty low, especially if they stand behind that leaded shield.
Yeah, unfortunately, the reason why they don't is not really radiation. Their main issue is comfort. Here's where the machine is usually placed, or here's where the gas is, or we have to add lines if we do that. And, I think that I'm going to make a big push with the information you've provided us today, that really based on data, all you're doing by not being open-minded and sitting in on a discussion about how we can put the rooms together is really doing us a disservice of surgeons, because we're the ones doing cases every day. If we have to put our hands under the tube, it really is uncomfortable. And then from a technical standpoint, it's bad. You can't even push the catheters in the right direction. And so I think that we're definitely going to mind your data and use it, not for a battle, but more for an opportunity of improvement and growth. So I know Dr. Peting is on, and I'm sorry, but we're about to start here. Okay, so I'm going to let Dr. Peting continue with the Q&A. And Dr. Kirkwood, I can only say thank you very much from all our family here at the Houston Methodist organization. It's been amazing and again, very eye-opening. I hope to see you again soon, and hopefully, as Dr. Lumsden mentioned, in person even better.
Thank you so much, Dr. Baker. Good luck on your case. Great to see you.
Bye-bye.
Hey, Dr. Kirkwood, I'm Eric Pete, and I'm one of the other vascular surgeons here and a graduate from Southwestern. So thanks for speaking to us from there. Great to spread the Texas spirit and Southwestern lore. A couple questions. I didn't hear you talk about leaded gloves, but that was kind of a fad for a while. And my understanding is that it actually increases your dose rather than decreases it. Can you speak to that some?
Yes. We haven't really studied those. I wore them for a few years, a few times a few years ago, especially for things like a fistulogram when I was kind of like right under there. And so it does decrease your hand dose, right? Because it's protection to your hand, but because it does drive up the dose of the machine because it's, radiopaque material. It's like putting, the rad pads, for instance, if you use them inappropriately and they're right under the beam, they're going to drive up the dose actually because it's something that's radiopaque. So overall, your scatter dose might be increased from wearing those leaded gloves, but they do decrease the dose to your actual hand.
Great. Can you talked a little bit about the new fellows, and obviously that's a concept that all of us face, right? Because you got lead foot, right? And you're like, oh my God. Have you actually studied who has control of the fluoro pedal and what the radiation dose is? Because I'm honestly kind of reluctant to give the pedal over to those guys, or I want to change the fluoro thing so that it says cancer, cancer, cancer. As long as that thing's on, right? With a big lead flashing light, like in a James Bond movie, because you can just get roasted when somebody that's inexperienced is on the pedal.
We haven't directly looked at that. I know that one of the first papers when we looked at the table position A versus B, we had to pull out some of those cases because if the fellow was the position A, it was an outlier that those cases were higher than if the attending was position A. So we had to eliminate all the cases where the fellow was position A to get some true data. So you're right. I mean, there is something true. And, we've often thought about, we haven't looked at this, but thought about looking at if the fellow is in position A in June or July when they start, is it much higher than towards the end of the year when they have some experience? So maybe some options for future work, but you're right. And now with the Sentinel Event policy being much lower actually than it was before, because before, to hit a skin dose of 15 gray was pretty challenging, right? But now they're saying any actual skin effect, which could be as low as 5 gray of skin dose, not rack, but still nonetheless, we are definitely going to be investigated more often. So what that means is your individual hospital has a policy now to investigate those cases and to look in them to see whether they qualify as a Sentinel event. So we all need to be careful who's on the fluoro pedal.
But I guess I've heard as well, though, from some really experienced, mostly cardiologists and radiologists, that the systems themselves are so much safer now. But I can only presume that the radiation toxicity events have gone significantly down over time.
I think that's true. I mean, in the 2 studies I showed, we didn't see any skin injuries. And so we had some patients with greater than 10 skin dose. Right. So, and we couldn't explain that. We just published the data and didn't have a great answer other than maybe there's some patient factors, or maybe it's not, the system is so much safer than it was in the years before when you saw it at 2 gray. But, we still, if you look at some of the data from the brain cancer and cataracts, there's still a higher prevalence of cataracts in operators than the general population. So I do think we are still, potentially at risk and really should do everything we can because, we're working longer. As much as I'd like to retire right now, I probably won't for quite some time. So, we're working longer and the cases are getting more and more complex. And so we really have to look out for our colleagues, our residents, our trainees, and ourselves.
Now, I do a lot of dialysis access and obviously we use a lot of fluoro, and that's That's a real challenge, obviously, right? Because it's hard to get the receptor close to the patient and you're right on it. We use an under-table shield with just a portable C-arm and such, and I honestly have the radiation tech run the fluoro rather than us, because I feel like, honestly, to have somebody that works with you a lot and then understands when you need fluoro, when you don't, you can really cut that back with a lot of the things that you described. Kind of similar to that, though, can you just talk about the different vendors and their attention to this live digital Zoom? Because some of the companies I feel like do that really well and incorporate into your workflow, and others seem behind. And I'm really surprised that some of the major vendors don't have live digital Zoom as an option to help reduce your dosing.
I think that's such a great question because, we do most of our FEVARs on the Philips system and they have it. But when we have to go to Parkland to do it on the Siemens system, we don't have it. And it's not as easily able at least on our Siemens systems. I'm not trashing Siemens. I mean, maybe somebody has it on their Siemens systems, but we don't have it at Parkland. And so we're not able to do the 2D roadmap versus the 3D. So a lot of these bells and whistles have been on the Philips machine. And I don't speak for any one vendor over the other, but you're right. They don't always have similar metrics. That's why we looked at the platforms on both systems, because both systems do have at least some type of platform of technology that can be added to the machine or comes on new machines that does decrease dose. And that was that VD11 Pure for Siemens and the Allura Clarity for Philips.
The portable C-arm that we use is almost as easy as an iPhone. I mean, they just kind of stretch their fingers on the screen and it blows right up. I think the challenge there is if you forget to collimate, you actually still wind up with a big field and you're missing an opportunity to reduce your dose. But with collimation and that digital live Zoom, I think you're absolutely right. I mean, you can reduce your dose substantially. I guess lastly,
can I ask a question?
You want to talk about? Yeah, sorry, go ahead.
So Melissa, I was watching you from down in our operating room, and of course we're surrounded by anesthesiologists, nurses, and one of the things that I think we spend a moderate amount of time talking about radiation safety, clearly not at the level that you're at, but can you say something about pregnant women in an operating room or a cath lab and what the steps are to protect them?
Yes. So, for pregnant, trainees or operators or OR staff, I mean, obviously, if you're OR staff, perhaps, it might be better for you not to be in the room if there's alternative nursing or tech support. But in terms of the surgical trainees, we've looked at this and just the faculty that are female and pregnant, it's important to have a fetal dose monitor under your lead as well as one over your lead. And it's important to even if you don't want to let your team know that you're pregnant, you need to let your radiation safety officer know so that they can, monitor your badge on a monthly basis. I know that the first time I was pregnant, I was a little crazy. So I wore 3 lead skirts, which I think was unnecessary and probably gave me some undue back discomfort. The second time I was pregnant, I went to 2 leaded skirts. And I think had I been blessed with a third child, I would have just worn 1 because it is pretty effective. And if you're doing the dose lowering techniques, it is very safe to be a pregnant trainee or faculty. Just wear that dose monitor under your badge.
The second question is, a lot of your studies relate to the interventionalist. We've always got an anesthesiologist sitting at the top of the table who are fairly oblivious in terms of dose reduction techniques and what we're doing. And do you have any data on what the risk and exposure is for somebody sitting at the top of the table?
Yes, we looked at that, and I could email you the paper. I think it was the FEVAR paper actually denotes anesthesia dose. And it was a little difficult to get that because we often have, a team of anesthesiologists, CRNAs that come in and out of the room. So we couldn't remind them each time to switch the badge. So we actually, for this one, put the badge on their anesthesia equipment so that it was there the whole case. And things we did to reduce that was to just pull in we have this like tall radiation shield that rolls in. Mm-hmm. So we actually rolled it in between the patient's head and anesthesia. So if they had to get to the patient, they just put their arm around it or walked around it. But for the majority of the case, while they're just sitting there, they were behind the leaded shield, and that dropped it off by like almost 99% of them. So, and they come in through the back, through the the sterile core. So they never, our team at least, didn't typically walk through the room. But for our surgical nursing staff and our circulating staff, their dose was actually pretty low, because even though they're in the room and they're circulating, remember the C position of that first picture that I showed you, the med student position, is almost 0 for even high dose cases. So being in the room doesn't necessarily mean you have a high dose, as long as you're about 4 to 6 steps back from the table. It's pretty safe.
And every now and again, you see people going under the table to adjust the Foley catheter, or yeah, I see your eyebrows going up. I mean, I think that's probably the message for anesthesia and our nursing staff is, you really, I'll let you say it. Is it a good idea to be underneath the table on top of that?
No, whenever I see someone under the table, I'm like, holy moly, why didn't you tell me that? Off the pedal. I mean, I'm blowing your brains out right now with the radiation dose. So yeah, it's always, if they have to just communication in the OR, if they have to go under the table to check something, or the arm fell off the table and they're retucking, as long as there's not a critical emergency, just give them time. Don't be on the pedal, communication, because it is a very high dose. It's the same dose as that first study I showed you to the lower legs, without the table skirt, because they're under there, and obviously it's their head and face and thyroid compared to the lower legs. So very dangerous. Always communicate when you have to go under the table.
The last question from me, and I'll give it back to Eric, is for a long time we were using these real-time dosimeters that show you, you've seen them, they have the little screen and they show you. And yet there was a huge amount of pushback from our radiation safety folks, because they said this is not approved. You can't measure the dose, and we really weren't. We were trying to use it as an education tool. I'm not sure how you fix this. If somebody comes and says your radiation badge, Dr. Lumsden, for the last 2 to 3 months is high, do something about it. And I always thought these real-time monitors should be built into these systems. I want to be reminded now that I'm getting high dose exposure, because it's a behavior modification process that needs to occur.
We do use the dose aware, and our medical physicists really like it. So I'm surprised your team over there didn't support the dose aware, because we find that it correlates pretty well. Anytime I've done a study with the dose aware and the nanodots, where I interpreted the nanodots and compared it to the dose aware, like we did that a couple times to make sure that we could transition to the dose aware instead of the nanodots, they were right on par with the dose that you were getting. I mean, they were closely paralleled in terms, and it gives you a case by case assessment. So we actually use it quite frequently.
Can you say a little bit about?
Right.
A little bit about what the nanodots actually are for folks who have not used them.
The nanodots are basically a chip that I get. I work very closely with our medical physicists, and they have like a chip reader in their office, and it's like a little photon thing that I showed it on that one picture on the hat. And it's very sensitive to radiation. And so that's how we did a lot of our initial studies looking at operator dose. I would clip those dots onto me, and then they just read out in a machine and give you exactly the background noise, the amount of dose they got from the case. And then on a spreadsheet, you can separate out the background noise. So it's just a way, it's basically like a dose aware, but it's, approved by the medical physicists, because it's how they study things. But we compared that to the dose aware, and the dose aware was pretty accurate compared to those nanodots, which is our gold standard, at least at our institution, deemed by our medical physicists for radiation measurements per case.
Thank you. Hand it back to Eric to close it out.
Alan, did you want to describe your Iron Man suit that you wear in the OR sometimes?
Yeah, it's
I don't know if Dr. Kirkwood's familiar with this, but it's pretty fancy.
I'm sure
is it
she
the zero
is.
gravity?
No, it's not the zero gravity. It's the one that you actually wear. The challenge with all of these things is the ergonomics of wearing them. This one's not bad. I mean, you get almost no radiation inside it. But all of these companies have a heck of a time getting everyone to accept it. I mean, the problem is us, actually, and I'm sure you come across that, is we don't prioritize radiation safety to anywhere near the level that we should. It needs to hurt. I think if radiation hurt, then we would all basically adjust it.
Yes, and I think I'm familiar with the suit you're wearing, and I agree. I mean, I think there's a lot of things out there, and we're resistant to it. That's why we were hoping, this face shield that we have patented, we're hoping it gets some traction, because it's not as cumbersome maybe as some other things out there. Like I know the ceiling mounted face shield or the ceiling mounted thing works great. We never use it because our boom in the OR is so like rickety, and you can't pull it in and you can't like turn it so that it's between you and the patient. And so it's basically ineffective because we don't use it. Whereas this face shield, we're hoping people will find less cumbersome, and kind of when they go get their hat, their gloves, their, whatever, they could get their disposable face shield. So more to come on that.
Thank you. It's a great comment about the extra radiation shield. In cardiology, I think they're great about using that because they're away from where they're working and such, and they've got the long catheters and stuff. If we're working close to it or the other leg or whatnot, it's really tough. And almost every live case I've seen, you see that thing in the back of the room, right? Hanging close to the ceiling. Do you want to comment on any of the people that have passed away from this? I mean, there's been some high profile early endovascular specialists who've really been pioneers that have then died from malignancies. And I think many of us have wondered, is that radiation exposure?
Yeah, I know it's tragic, but it's hard to tell with this kind of stuff, right? Because cancer in general is very prevalent in the general population, and you have family history and genetics, and it's hard to know. That's why I think the data out there is so mixed in terms of, what is our real stochastic risk and what is our deterministic cataract risk. It's really, I think, hard to say because, in the general population, things happen. But when you look at the literature, at least for brain dose, for neuroblastomas on the left side of the brain, and you look at operators, in the general population, the left and right are kind of the same frequency, whereas in operators, it's typically, the left side. And so that raises the question, well, why is that? But it's still such a rare occurrence that it's hard to really define a cause and effect, but it's enough to instill some concern to make us, hopefully motivate some positive change.
So I'm program director here for our vascular surgery programs of both the integrated and the fellowship, which is a blessing and a challenge all wrapped in one package. Can you comment on training for your trainees and how you get early and hopefully effective awareness of radiation exposure, et cetera? Because I think, these young people are impervious and, and I think it's challenging to really get that message across strongly enough.
Yes, I mean, I think it is. Every different program has, different accreditation that they have to do for their hospital for fluoroscopy. So our fellows take that. But I make a point in the OR to always say what I'm doing. So especially in the beginning, I'm like, I'm lowering the II now to decrease our radiation. I'm moving the beam away from your legs. Watch your, your ankles. It's going to swing the other way or whatever to lower radiation. I'm raising the table. So I try to, every motion I do, I try to explain what I'm doing so that they kind of, get it through reiteration. But it is a problem. I know that it's, I was fortunate enough to be able to write some of the questions for the VSAP. It's a part now of the exam and the training exam. So I think that's important to keep the focus on, because you're right. They feel that they're impervious, and it's just like you think you're never going to have back pain, and all of a sudden you wake up one day and you can barely tie your shoes because you've been wearing too much lead. So it does catch up with us over time.
So we have that on some of our simulators. I don't think that we use that function of it enough to say, hey, do you realize you use 3 times as much radiation as somebody else would have in this kind of case? Great. But definitely that needs more exploration and emphasis for sure. I guess lastly, I'd say, so your new device you've created, is that available on Etsy, Amazon Prime? Where can we pick these up?
Well, right now I'm hand making them with a sewing machine. So I'm really hoping industry picks it up. No, but we're the university, I have the patent through the university. So they're talking to big people who are talking to big people. And I'm just a little person with the sewing machine and an idea. So we'll see. Maybe one day it would be available.
Can I ask one last question?
You've got to put your design online.
Yeah, look, I'm sure because of your visibility in this, you get asked to review malpractice cases. I mean, 2 questions. Number one is, how prevalent are lawsuits around radiation injury, number one, to patients? And number 2, has there ever been a lawsuit where a healthcare worker has sued their organization because of perceived effects of radiation?
That's a great question. And I don't really know the answer to that. I don't think it's very prevalent because I haven't been involved in any expert witnesses. Sometimes, we all get requests for other things, but in regards to radiation, I haven't had that experience. And in my experience, I've only met 2 people who had a radiation burn. One was a young patient who had had a horrible pelvic AVM, and as a child had multiple embolizations to the point that now there was just this, horrible wound on his back that couldn't heal, and plastics was involved and such. So, and then the other patient was that one patient that I showed that also had multiple embolizations before. So I don't know how prevalent it is. That would be an interesting question. I'll look that up and I'll get back to you the next time that we're maybe at the SBS.
All right.
That is a fascinating question.
Well, I think we're right on time. Thank you very much indeed, Melissa. It's very, 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 very helpful. Actually, it's just one of those really nice, practical presentations that we can all take something away from. Appreciate you.
Well, thank you so much for the opportunity. I really enjoyed it. If there's any additional questions, just shoot me an email.
Thank you.
Thank you so much.
Thank you. Have a great day.
Good job.